Thank you everybody for joining us. So welcome. We're really looking forward to spending the next hour with you. We're going to be talking about the labor and delivery process and newborn life. If you have any questions at all during the webinar, you can click on the Q&A button on the bottom left-hand side of your screen. So Summit Health is one of Tri-State's leading providers in primary and subspecialty care. We have subspecialists in over 80 different areas, and we see patients at more than 340 different locations. We also have our care partner, CityMD. They're an urgent care provider, and they have locations all throughout New York, New Jersey, and Connecticut. Summit Health and CityMD are one connected care team. So we work to have streamlined communication between your primary care doctor, your subspecialty doctors, and your urgent care providers. We're all one team and we work together. So now for some introductions. So my name is Dr. Julie Henderson. I did my medical school training at SUNY Upstate in Syracuse, New York, close to where I grew up. I then did my pediatrics training at Yale New Haven Hospital in New Haven, Connecticut. I worked as a pediatrician for 2 years in Connecticut before joining Summit Health in 2023. And I now work as a pediatrician in New Rochelle, New York. I live in Westchester County with my husband and my 11-month-old daughter. She's going to be 1 year old this month in October. So I have firsthand experience on what it means to be a parent and all of the challenges and the joy that that brings. I'm passing it on to you, Julianne.
Hi, my name is Julianne Biroschak, and I'm an OBGYN physician practicing in Greenwich, Connecticut. I did my medical school training at Jefferson Medical College in Philadelphia, followed by residency at George Washington University in Washington, D.C. I started my career as practicing general OBGYN at Mount Sinai Hospital in 2013. After 5 years, moved here to Greenwich and have since been with Summit Health, which was formerly West Med Medical Group. When not working, I spend most of my time with my family and 3 children who are 3, 6, and 9 years old.
Okay, so time for a poll. So, which one of the following best describes you? Are you an expecting parent, a parent with a newborn, a family member, or support person? And no matter which category you fall into, we hope you find the information tonight really helpful. So we'll give everybody a few minutes to answer the poll. Okay, great.
Wonderful. Yeah. I see we have mostly expecting parents here today. I hope you'll find this topic educational. Today, I will cover the last few weeks of pregnancy, followed by labor and delivery, and touch upon postpartum care. Dr. Henderson will then focus on baby's health in those first important weeks of life. So I thought I would start about talking about the due date. The due date is established by adding 280 days or 40 weeks to the first day of your last menstrual period and is most accurate if consistent with the first trimester ultrasound. And although your due date is defined as 40 weeks, only 4% of patients will actually deliver on this day. The majority of patients will go into labor between 38 and 41 weeks. In the last month of pregnancy, we will recommend weekly prenatal visits. At these visits, you can expect that we'll check your blood pressure, as we're going to want to look out for hypertension or preeclampsia. We'll also offer to check your cervix. Examining the cervix can give us an idea if your body is ready for labor. When we check the cervix, we look at 5 factors: whether it's dilated or starting to open, whether it's effaced, which is how thinned out it is, its consistency, its position relative to the baby's head, and lastly, the fetal station, which is how high or low the baby's head is relative to the ischial spines of mom's pelvis. A more favorable cervical exam is predictive of spontaneous labor and is also predictive of how you might respond if undergoing an induction of labor without cervical ripening. At your 36-week visit, we'll also recommend to check a culture for Group B strep. Group B strep is a bacteria that 20 to 30% of women carry normally. However, this can cause an infection in a baby, so if it's positive, we recommend antibiotics while in labor. At these last visits, I also think it's a great time to discuss with your doctor or midwife your birth plan or birth preferences. In my experience, most patients don't type up a formal birth plan, although you are welcome to, but they tend to bring up questions about their labor preferences, and we'd love for you to ask us so that we can go through everything together. Our number one goal is to provide a safe birth for you and your baby, but also to support your preferences and create a joyful experience. Once you're 37 weeks, you're considered full term. At this point, we'll discuss with you when to call in labor. We like you to follow the 5-1-1 rule. So we want you to call once the contractions become very painful, every 5 minutes, lasting about a minute for an hour. We'd also want you to reach out if you think the water breaks or if you have vaginal bleeding. And probably the most important thing I always tell my patients is the importance of fetal movement. Your baby moving means the baby is doing well. So if you're ever worried about decreased movement, we consider that an emergency. We don't want you to wait and wonder at home or message us on the patient portal. This is a time where you should call, even if it's the night or a weekend. I also wanted to talk a little bit about induction of labor. Induction of labor may be recommended if there are medical issues for either you or your baby. For example, gestational diabetes, high blood pressure, fetal growth restriction, or low amniotic fluid. Induction may also be recommended if you're in the late term period. So this is between 41 weeks and 41 weeks and 6 days. This is to prevent you going post-term, which is past 42 weeks, where risks to the baby increase. I also want to touch on an important topic, which is elective induction of labor. Many patients may desire or elect for induction of labor that's not medically indicated. In the past, we always thought that induction of labor would increase the risk of a cesarean delivery. However, there was a groundbreaking study done in 2018 called the ARRIVE trial. This trial was led by researchers at Northwestern University and looked at 6,100 first-time moms in the United States with an uncomplicated pregnancy and whose babies were in head-down position, and it was at 41 medical centers. It randomized these patients into induction of labor at 39 weeks versus expectant management, allowing labor to happen spontaneously with induction if you went post-dates. The primary outcome, which was to look for risk of severe neonatal morbidity or mortality, showed no difference between the two groups. But very interesting, the elective induction group had a very slightly smaller risk of need for cesarean delivery and a smaller risk of mom getting hypertension. So a question you might ask, and we ask ourselves when we take care of you, is it better to induce labor at 39 weeks or wait for labor to start naturally? The answer to this question, in my opinion, is that choosing an induction or waiting are both safe options, and this should be individualized to each patient, and you should discuss this with your doctor. Because although an induction of labor is safe, it does require additional intervention. We can go to the next slide. On this slide, I wanted to talk about labor and delivery. Labor is defined as regular painful contractions resulting in cervical change, whether that's dilation or effacement. The first stage of labor is when you're between 0 and 10 centimeters dilated. Early labor is less than 6 centimeters, and in this phase, contractions tend to be more irregular. In active labor between 6 and 10 centimeters, contractions typically become more regular and more painful. Patients are more likely to request an epidural during this phase of labor, and the water is more likely to break spontaneously. The second stage of labor is from the time you're fully dilated or 10 centimeters until delivery of the baby. and this is the stage where you'll be pushing. Pushing can take anywhere from a few minutes to a few hours, and we consider it normal for a first-time mom who has an epidural to push for up to 3 hours. The third stage of labor is from the time the baby's out until the time the placenta is delivered. The average duration of this stage is about 5 to 6 minutes. However, if 30 minutes have gone by and the placenta is not ready to come out, your doctor may recommend manual delivery of the placenta. What to expect on labor and delivery. One is you won't be alone. You'll have your support team with you, advocating for you, and your medical team there to support and answer all of your questions. So most patients will come with a partner or a close family member or friend. Some patients will opt to have a doula as well, and you'll have your nurse and your doctor. In terms of common interventions, I recommend all of my patients have an IV in place during labor. And this is so that we're prepared in case of something unexpected like an emergency. An IV will also allow you to get antibiotics if indicated for group B strep. It's necessary if you were to need Pitocin for augmentation, and also to give you fluids before placement of an epidural if you desire. Another thing to expect is fetal monitors. Specifically during the active phase of labor, we're going to want to monitor the baby. We have an external ultrasound monitor to monitor the baby's heart rate, as well as a contraction monitor to monitor the frequency of the contractions. Most labor floors now have wireless monitors available as well, which is really nice for patients who are trying to move around a lot. I also wanted to touch on this slide about labor augmentation. So as you can imagine, dilation does not always follow an expected curve during labor, and sometimes it can stall out. If that were to happen, your doctor may offer you breaking the water or starting a medication called Pitocin. Pitocin is a medication that acts like the hormone in our body called oxytocin. This will make the contraction stronger and more frequent. I want you to know that every labor experience is unique, and I recommend being patient with yourself and asking your questions along the way. On this next slide, I wanted to talk about pain management. There are many non-pharmacologic or natural options to help with pain. One would be movement, specifically on a birth ball. Also water immersion, such as a shower. And I recommend that you can take a warm bath if at home in early labor and the water has not broke yet. Application of heat and cold, massage, acupuncture, deep breathing, and hypnobirthing are excellent options to help with pain. Evidence also shows that listening to music can decrease anxiety and pain during labor. And I find that many people will come prepared with their playlist that they want to hear during labor. Sometimes the playlist has relaxing music and sometimes it's high energy. Either way, I think it can create a great ambiance in the labor room. In terms of pharmacologic options, over 70% of patients in the United States will opt for regional anesthesia, most commonly an epidural. An epidural is a procedure where the anesthesiologist will place a tiny catheter into the epidural space of the spine. They can infuse medication into this space, which will create numbness and loss of sensation in the lower extremities. Because of this, when you have an epidural, you won't be able to walk. However, you should be able to bear down to push your baby out. A great feature of an epidural is it does not cause sedation in you or the baby. And a common question that I get asked is, when will it be too late for me to get the epidural? The answer to that question is not absolutely straightforward, but I typically tell my patients, as long as you can sit still for it, we can get your epidural placed safely. Other less commonly used options are nitrous oxide. This is a tasteless, odorless gas that can be inhaled during labor, and it doesn't numb pain, but it does reduce anxiety, increases the feeling of well-being, so pain is easier to deal with. I have yet to work at a hospital that offers nitrous oxide. However, I know that it's up and coming and making a comeback in the United States and can be a great option to help. IV narcotics are sometimes used as well for pain management in labor, but we typically try to reserve that to the first stage of labor because those do go into your bloodstream, they cross the placenta, and we don't want to create, and they go to the baby. So we don't want to create sedation in the baby when it's born. So we try to limit that. And local anesthesia is most useful for a patient that may undergo a natural labor but might need a repair of a laceration. We'll typically use local lidocaine. In general, anesthesia is very rarely needed on labor and delivery. It's usually if an unexpected emergency C-section is needed and we don't have time or ability to get spinal anesthesia in. I want you to remember that you can use a mix of these options for pain control, and only you would know your level of pain, and only you can make your decision. And you should be supported by your care team and your support person, whatever decision that you make. On this next slide, I wanted to shift gears and talk about the alternate to that spontaneous vaginal delivery. So I thought if you can imagine a scenario where you're pushing for several hours, the baby's almost out, but possibly there's a fetal heart rate issue for which your doctor thinks you need to be delivered sooner. You may be a candidate at that time for what we call operative vaginal birth. This is either use of vacuum or forceps to assist in delivery. These are performed in about 3% of vaginal births in the United States. A vacuum is when a small suction cup is applied to the baby's head, and forceps are big metal spoons that go around the baby's head. And we would use these to create gentle traction while at the same time as mom is pushing to help with delivery of the baby. Your doctor would assess to see if it's safe and you're a good candidate for this, and they would review with you the risks and benefits. In terms of cesarean delivery, most people have heard of this. This is C-section, and it is performed in 1 out of every 3 pregnancies in the United States. That number includes those that need a C-section in labor, but also those patients that may have a C-section scheduled for medical indications. For example, if the placenta is low-lying or a previa, if the baby's in breech or transverse position, or if you have twins where baby's heads are not face down. C-section in general does come with more maternal risks and in general a harder recovery than vaginal delivery. So we try very hard as your doctor to get you that safe, healthy vaginal delivery. And I want you to know that just because you need one C-section doesn't mean you can't try for a vaginal birth in a future pregnancy. And your doctor would review with you the risks and benefits of this option. The bottom line when it comes to alternates to that spontaneous birth, all decisions for your baby's birth should be shared, and you should ask your questions and get them answered. We can go to the next slide. Okay. So for aftercare, I wanted to talk on this slide about what happens immediately after the baby's born. So this should be the most joyful time. We initially recommend what we call delayed cord clamping. So once the baby's delivered, we like to not clamp the cord, but let it naturally pulse so that the majority of the blood will go back to the baby. And we usually do this between 30 and 60 seconds. At that time, we will clamp the cord and we'll offer your support person to see if they want to cut the cord, which they may opt or not opt to do. At this time, your nurses and your care team will also be assigning APGAR scores to the baby, and they may weigh the baby as well. Most patients are able to initiate skin to skin at this point. This is where your baby is laying on your chest. Skin to skin has great health benefits for you and the baby. It helps stabilizes their temperature, it helps with their breathing, it helps your breast milk to come in and to establish breastfeeding. Sometimes a patient can't undergo immediate skin to skin. For example, if the baby needs evaluation by the pediatric team, or if in a rare case, baby has to go to the NICU, or if you're having a C-section and the doctor's finishing up your surgery. I want you to know that nothing is lost because as soon as you and your baby are ready, you can initiate skin to skin. Your care team will also recommend a vitamin K injection to allow for blood to clot normally and prevent bleeding, as well as an antibiotic eye ointment to prevent an eye infection. They will obtain consent with you before doing this for the baby. A lot is going on, as you can see at this time. But while you're focusing on baby, your doctor will also be repairing lacerations, assessing and managing bleeding, and finishing a C-section in that case as well. You can expect to spend about anywhere 1 to 3 hours in your room or your post-op area before transferring to the postpartum floor. Once on the postpartum floor, you'll have very educated nurses who can help you with incision care, perineal care, and pain control, and lactation support from both your nurses as well as lactation specialists who I think are like baby whisperers. They are wonderful. My advice in this stage is use your resources while in the hospital. Get rest and enjoy the snuggles. Lastly, I wanted to touch on postpartum care. Thank you. In terms of physical health, I sort of expect pain, soreness, and discomfort to steadily improve over the next several days to weeks. If you were to feel that your pain is not improving or it's getting worse, that would be a reason to reach out to your doctor. You can also expect some vaginal bleeding that's on and off for about 6 weeks. And this occurs because the uterus, when you leave the hospital, is about a 20-week size, but it has to shrink down, and it does that over the next 6 to 8 weeks. And when it does, it will cause some cramping and bleeding. You do want to look out, though, for what we call postpartum hemorrhage. So if your bleeding becomes very heavy and you're soaking more than a pad an hour, several hours, that's a reason to reach out to your doctor and be evaluated. Other things to look out for in the postpartum period is mental health. Baby blues is a condition that can affect about 40 to 70% of patients. This is typically in the first 1 to 2 weeks after delivery, and a patient might feel very tearful, have some feelings of anxiety or depression, as well as exhaustion. Baby blues will typically sort of self-resolve by 2 weeks. If your symptoms are persisting longer than that, or the baby blues seems very severe, it could be that you're developing some postpartum anxiety or depression, and this would definitely be a time to reach out to your care team. Typically, if my patient reaches out, we try to set up an immediate virtual visit just to check in and see how she's doing. We do have treatment options ranging from therapy to medications, and you're definitely not alone. Your doctor will recommend a postpartum visit. They may bring you back at 6 weeks and also 2 weeks. But at your 6-week visit, you can expect that your doctor will do a physical exam to assess healing and breast health. Your doctor will also discuss how you're doing with pelvic floor health and possibly give you a referral to pelvic floor physical therapy if you desire. They'll talk with you about birth control and also check in on mental health. So, one piece of advice I'd like to give you in the postpartum period is it is not easy. It's really hard, and I'm sure Dr. Henderson will speak to this more. And I believe that we're meant to be a community when we have our babies. So I want you to accept all the help you can get. For example, if your mother-in-law wants to bring over dinner or help fold the laundry, don't be a hero. Let your family help you because you need to rest and recover and balance that out as well. So now I'm going to pass things off to Dr. Henderson.
All right, so now we're going to switch gears and talk about caring for your baby. And we're going to start with talking about breast and bottle feeding. So, newborn babies, they feed on demand. That's typically on average about every 2 to 3 hours. Some babies can cluster feed where they want to feed every hour. And in the beginning, especially, babies can be pretty sleepy. So, you may need to wake them up to feed. And if you find that your baby is sleeping and it's been 3.5 hours, it's recommended to wake them up so that they can feed. So, how do you know if your baby is hungry? There's different feeding cues you can look for. Having the baby smack their lips together, they may put their hands in their mouth, they may make a sucking motion with their mouth. There's a normal baby reflex called rooting, where if you stroke the baby's cheek, they'll turn their head to that side and open their mouth, showing that they're ready to feed. Also, crying and fussing in general, that could be a cue that your baby's hungry. If you're interested in breastfeeding, this should be started right away. So, as Julianne mentioned, in the hospital, right after the baby's born, you could have the baby come on your chest and you could start having them try to latch to breastfeed. It's very normal in the beginning not to produce very much breast milk. In the beginning, there is this thick, yellow, very nutrient-rich substance called colostrum that's produced, and that is in small quantities, and that over the coming days will increase into the more what you picture as traditional milk, the white, more thin milk. So again, very normal not to produce a lot of milk in the beginning, and this will slowly increase over the first couple of days. That's why it's super important to let your body and to let your breasts know that you need to keep producing milk. So we recommend having the baby latch at least every 3 hours to help stimulate the milk production. If for some reason there's any issues with latching, that would be a reason to reach out to a lactation consultant. So lactation consultants are amazing. They should be available in the hospital right after the baby's born. They can work with you with positioning, with holding the baby, figuring out what a latch even means. And then they're also available in the outpatient setting. So many of them will do virtual visits and they'll even come to your house within that first week too. So lactation consultants are amazing. What are some of the benefits of breastfeeding? Well, when you breastfeed, the mom passes on antibodies to the baby, which helps with immune protection. So this can help prevent your baby from getting sick. Benefits to baby also include decreased rates of allergy, decreased rates of asthma. Benefits to the mom include decreased rates of breast cancer and ovarian cancer. And it's great in general just to have the baby have that emotional support and to bond with you. However, if for whatever reason you can't breastfeed, you're not interested in breastfeeding, it's just not for you, that is completely, completely okay. It is totally fine to give your baby a bottle with either pumped breast milk or with formula. So if you do choose to give your baby a bottle, you can either give them pumped breast milk, which you can talk with the lactation consultant more about, how to pump the milk, or you can give them formula. The most common formula brands available in the hospital are Enfamil and Similac, but there's so many brands out there, and all of them are great options. Some popular ones include Bobby, Kendamil, but all of them are great. And typically with the bottle, in the first day or so, babies tend to take maybe about an ounce per feed. Over the next couple of days, they'll probably increase to about 2 ounces per feed. After, a week or so, they'll do maybe 3 ounces per feed. But there's no one size fits all with feeding. Every baby is different. So looking for your baby's hunger cues that I mentioned above, that's how you're going to know if your baby's hungry. Okay, so moving on to bathing, diaper changes, and skincare. So all babies have their umbilical cord stump after they're born. This will typically fall off on its own within about 7 to 10 days. You don't need to do anything to it, just keep it nice and dry. It will shrivel up and fall off on its own. And then typically within about a day or so, it should look very dry, and then you can give your baby a bath. If for whatever reason you want to clean your baby when the umbilical cord is still attached, you can get a nice soft washcloth and some warm water and just give the baby a sponge bath. Once it's time to give your baby a bath, you can get these baths. They're available that have a sling or a place where you can help to hold your baby. We want to use warm water, but definitely check it with your hand first to make sure that it's not too hot. And then it's recommended to use a very mild baby soap. So most baby soaps are free of fragrances, dyes, scents. A popular brand that people use is Baby Dove. And you can use a little bit of soap on their body and on their head, but you really don't need to use a lot. Babies don't have body odor and get dirty the same way that we do as adults and the same way that older children do. So they really only need to be bathed maybe once a week, maybe twice a week, but their skin is very sensitive, so we don't want to be bathing them every single day. Once a week is usually okay. And, also on that topic of newborns having sensitive skin, less is more, so you don't need to be putting lotions on the baby. You can kind of leave their skin be. And it's very normal for babies to have this dry, peely skin in the beginning, in the first week, first couple weeks. And this is because your baby was in fluid in mom's belly for 9 months. Now they're out in the real world. So that dry, peely skin will go away on its own. You don't need to do anything to it. Just leave it be. So talking about diaper changes, with pee diapers, babies will typically have one pee diaper on the first day of life, two pee diapers on the second day of life, three on the third, four on the fourth, and then after that, we expect them to have many pee diapers a day, usually at least 5 or 6 wet diapers a day. With pooping, there's a whole range of pooping. So in the beginning, babies will have this black sticky poop called meconium. That will transition over a couple of days into more seedy yellow-brown poops. And as pediatricians, we like to say that babies poop the rainbow, meaning that baby poops can be a lot of different colors. So the poop can be yellow, it can be brown, it can be green, it can be orange. All of those are fine. If for whatever reason the poop looks red, like there's blood in it, if it looks white, or if it goes back to looking black, that would be a reason to be concerned. So red, black, white poops, let your pediatrician know about those. The rest of them are okay. In terms of the frequency of the poops, there's a whole range. So some babies will poop every day, multiple times a day. And then some babies can go a few days without pooping. Both of these are fine, especially in babies who are exclusively getting breast milk and being breastfed. They can even sometimes go up to a week without pooping. So don't be alarmed, but if you have any concerns, definitely let your pediatrician know. If you end up having a baby boy and you choose to have a circumcision, this will be performed in the hospital. Unless there's any concerns, sometimes it will be performed with a urologist, but many times this will be done in the hospital shortly after birth, after the baby pees. In terms of caring for the circumcision once you're home, all you need to do is just put some Vaseline or Aquaphor on the circumcision site. That helps it to heal. It's normal as the circumcision heals to have a yellow film as it heals over the penis. This is okay and nothing to worry about. If you have a baby girl, you may notice that your baby girl has a small amount of vaginal discharge or even a scant amount of blood coming from the vagina. This is also normal. This is just your baby girl having withdrawal from being exposed to mom's hormones. And this will also go away on its own. It's nothing you need to worry about. A quick word about jaundice. So babies can look jaundice or can look yellow. So you'll basically see all of their skin is looking yellow, the whites of their eyes can look yellow, and the inside of their mouth can look yellow. This is from something called bilirubin. All of us have bilirubin in our bodies, but in the beginning, babies can't get rid of it as well, so they can sometimes look a little bit yellow. This is something that in the hospital, the pediatricians will be on the lookout for. If they have any concerns, they'll do a blood test to check this. And then when you see your pediatrician once you leave the hospital, this is something they can follow as well. But if for some reason when you're home, you notice that your baby is looking way, way more yellow, like highlighter yellow, this is definitely something to let the doctor know about. So now moving on to sleep. So newborn babies should sleep in a crib or in a bassinet. They're recommended to be in the parent's room for the first 6 months of life, just because, as I mentioned before, you're going to be feeding them pretty frequently. They're going to need diaper changes. So it's helpful to have them close by to you in your room. It's super important for babies to always, always, always sleep on their back. So this is the safest way to prevent SIDS, which is sudden infant death syndrome. So always put your baby on their back. It's very normal when you put the baby on the back. Sometimes they will almost like roll over onto their side. That's okay. Just make sure you put them down on their back and never on their stomach. It's okay to use a swaddle to wrap your baby nice and cozy like you see this baby in the picture. There's also a lot of great sleep sacks available that you can zip the baby into and then Velcro their arms to have them nice and tight and snug. And if you think about it, your baby was snuggled up in your body for 9 months, so they want to be snuggled once they're outside the womb as well. And in the crib, we don't want any fluffy blankets, stuffed animals, pillows, only your baby swaddled nicely on their back in the crib. And the AAP, which is the American Academy of Pediatrics, does not recommend co-sleeping. This is having your infant in your bed with you, as this also increases the risk of SIDS. And one other thing about about babies sleeping, which I never really realized until I had my own daughter, babies are really, really noisy sleepers. So they can flail their legs around, they make little cooey, grunty noises, and they're pretty loud when they sleep. This is normal, so don't be alarmed by it. But if there's any concerns, you can always ask your pediatrician about it too. So now moving on to fevers. So fevers are considered an emergency in the first 1 to 2 months of life. This is because babies' immune systems aren't as developed and they can't fight off infections as well. So a fever is something that we take super seriously. A true fever is any temperature at or above 100.4 degrees Fahrenheit or 38 degrees Celsius. The best way to check a temperature in a baby is with a rectal thermometer. It's the most accurate way to get a temperature on them. So make sure before your baby's born or when you go home from the hospital, make sure you have a rectal thermometer so you can check your baby's temperature at home. And this isn't something you need to be doing all the time. Reasons to check a temperature would be if your baby's feeling warm, if they're not feeding as well, if they're breathing funny, anything that looks alarming to you, that would be a reason to check a temperature. And if your baby has a fever, you need to let your pediatrician know right away about the fever. If the baby is less than a month old, they're going to need to be seen at the emergency room to evaluate them, just because sometimes the fever can be the only indication that they're sick. And if they're between 1 and 2 months, we still take the fevers really seriously. So definitely let your pediatrician know right away. That being said, we really want to avoid having your baby being exposed to sickness and being exposed to large crowds. So it's important to keep your baby away from people who are sick. Even if people say they have a stuffy nose because of allergies, it's better to be safe than sorry. So just have people stay away if they're not feeling well. Have people do really good hand washing before they hold your baby. It's really not recommended to have anybody who's not mom and dad kiss the baby because this is a way that germs can spread. And we really want, the baby to stay away from very large crowds in the beginning where people are coughing and sneezing and spreading germs. Another note about that is anybody who's going to be in regular contact with the baby, so parents, other caregivers, grandparents, they should be up to date on their Tdap vaccine. This is recommended once every 10 years. And then it's also recommended for these people to be up to date on their seasonal vaccines that includes the flu vaccine and the COVID vaccine. Okay, so a quick word about car seats. So it's really important to get to know your infant car seat before the baby comes home. So make sure you have a car seat well before the baby comes. Take it out of the box, get to know it, play with the straps, play with the buckle, and even bring it out to your car and try and put it in your car because you'll need the car seat to take your baby home from the hospital, and you don't want to be doing this the day you leave the hospital. So get to know your car seat before the baby comes. The car seat goes in the back seat facing the rear of the vehicle. And it's important to have your baby super snug in the car seat. So the straps on the shoulders should be super snug to the baby's body. You should only be able to fit one finger below the straps on the car seat. And we want the chest buckle to be over the nipple line. So, one thing to mention is that in the wintertime, there's these super cute snowsuits that babies wear. They're really, really cute, but we don't want the baby to be wearing these snowsuits or any fluffy outfits while they're in the car seat, just because if they have on a thicker, fluffy outfit, they're not going to be as secure. So if it is cold, if it is wintertime, you can put your baby in 1 or 2 thin layers, put them in the car seat, and then you can put a hat on them, you can put a blanket on top of their legs, and that can keep them warm, but just no fluffy outfits while they're in the car seat. Okay, so a quick word about vaccines and vitamin D. So, in terms of vaccines that we think about in the hospital, so the hepatitis B vaccine is recommended for babies shortly after birth while they're in the hospital. Another shot that is recommended while you're in the hospital is called Beyfortus or nirsevimab. This is a monoclonal antibody that protects against RSV. So for those of you who don't know what RSV is, RSV stands for respiratory syncytial virus. This is a virus that is around during the fall and winter months. And in adults, this causes cold symptoms, so runny nose, cough, common cold symptoms. But in babies, they can get super sick from this virus. They can have breathing problems. They need to be hospitalized sometimes, even need to be on a vent, need oxygen. So this is a virus that we really want to avoid having babies get. So this shot called Beyfortus, it came out within the past 2 to 3 years. And us as pediatricians, we were super excited about it because this has been really great at preventing babies from getting really sick from RSV. So this shot is available to babies up until they're 8 months, but the earlier they get it, the better. So it is recommended between October and March. You can even get it when the baby's in the hospital. This is a really great shot to consider getting. After you leave the hospital, the next round of vaccines is given around 2 months. So this includes the DTaP, polio, the next hepatitis B, pneumonia, and rotavirus. If you want to know more about vaccines, though, you can look at this great webinar from September 17th. They touch more on the vaccine schedule from kids up to 5 years old. So you can look into that more if you have other questions about vaccines. And one quick note about vitamin D. So if you are breastfeeding your baby or if they're mostly getting breast milk, it's recommended for the baby to get vitamin D supplementation just because the vitamin D doesn't pass as much through the breast milk. So this can be purchased over the counter at a pharmacy or on Amazon. You can get infant vitamin D drops. And we just recommend giving the baby 1 drop once a day. If you're giving your baby mostly formula, you don't have to worry about this because the formula already has the vitamin D included in it. Okay, so that is all for the content portion. So now we have some questions. So I can start with one of our first questions. So how often should newborns be fed and how can parents know if their baby is getting enough? So as I mentioned before, newborns usually feed around every 2 to 3 hours, but it really depends. You want to look for those feeding cues of when they're hungry. So some of the things I mentioned earlier. And how do we know if they're growing? So your pediatrician is going to see you really frequently throughout the first month. So we will see you when you get home from the hospital, usually within a day or so, at 2 weeks, at 1 month, and at 2 months. And sometimes we'll see you even more frequently than that if we have any concerns about the baby's weight gain. And at all of these appointments, we're checking in on the growth, we're checking the weight, the length, the head circumference, and we're tracking these on a growth curve. If all of that looks good, that tells us that your baby is getting what they need, so they're getting the nutrition that they need to grow. So this is something we're following pretty frequently. And I'll pass it off to you, Julianne, for the next one.
Thank you. Okay, let's see. Another question is, how can I best prepare myself physically and mentally for labor and delivery? I would say in terms of physical health, I think it's great to continue to stay active and fit throughout your pregnancy. When you're pregnant, it does not mean you can't exercise. And I actually encourage you, if you're used to exercising, to continue that throughout the course of your pregnancy. But your exercise should be more of a moderate or comfortable level. So one thing you can gauge is if you're too winded to talk through it, it's too much. But I think staying fit can help with actually your mental health and your physical health. And another thing I'd say in terms of mental health is go in with an open mind. You know, parenthood from the time you're pregnant to delivery to being a mom or a father comes with a lot of unexpected challenges. And I think if we go in with an open mind, ready to pivot, it makes things a lot more easy to deal with. Because remember, your number one goal in labor is to have a healthy mom and a healthy baby. Dr. Henderson, do you want to look at the next question?
Yes. So, okay, next question we have is what are some meaningful ways partners can support both mom and baby in the first month? So, the biggest thing I would say is to work together as a team. So, helping with diaper changes, if you're bottle feeding, taking turns feeding the baby, cleaning bottles, cleaning the breast pump parts, all of those things you can do together and you can help each other with. And even more so, just things around the house. So helping to tidy the house, making each other food. Maybe one partner watches the baby while the other partner naps and vice versa. I would say just really working together and taking turns because that's going to be the best way that you take care of each other and take care of the baby. And Julianne, you can take the next one.
Okay, great. Another question is there anything I can do in advance to prepare for breastfeeding? I would say that one great option is insurance companies now will cover, or most plans, a free breast pump for each pregnancy. A breast pump can be super valuable, whether you're planning to exclusively breastfeed or do a combination of things, you still want to have a breast pump available in the case where you can't get the baby to latch or you need to pump. So they make wonderful pumps. I usually tell my patients, call your insurance, see which companies they use to cover the pump. You usually choose your pump. They send us a requisition to sign a prescription and they'll mail it to you. Another thing is to be prepared for lactation support. The hospital I deliver at, which is Greenwich, has an amazing lactation team. And what I find is that they'll provide amazing service while you're there. But when you go home, it can be extremely valuable to get a second lactation consult because it's a whole different ballgame. Hopefully by then your milk has started to come in more, your baby is growing, possibly more alert and more hungry. So you can ahead of time figure out if it's covered by your insurance, who's in network in terms of lactation consultants, and line up some resources so that you're ready to go with that.
Okay, so another question we have is what are the most common challenges that parents face in the first month and how can they manage them? So, I would say one of the biggest challenges is dealing with the crying. So, babies are inherently gassy, fussy creatures. They communicate by crying, so there's a lot of crying. This tends to peak around 6 weeks, where the crying gets to be a lot at 6 weeks, and it tends to lessen after that. But it can be a lot to deal with the crying. So, when a baby is fussing or crying, I would say the first thing to do is do the mental checklist of are they fed? Are they changed? Are they comfortable? Are they too hot, too cold? If you've gone through those things and they're still fussing and crying, you can move on to the ways to soothe the baby. So bringing the baby in a dark, quiet room, rocking them gently, shushing them, playing quiet, calming noise. And honestly, sometimes you do all these things and the baby is still going to fuss and cry, and that's okay. So really just, working with your partner to, you know, deal with the crying together. And if the crying ever becomes to the point where you're feeling overwhelmed and you can't deal with it, it is completely, completely okay to put your baby down on their back safely in their crib or bassinet and step away for a few minutes. So go get a drink of water, go get some fresh air, take a minute to regroup because we want you to be in a good place to take care of your baby, and your baby will be fine for 5 minutes in their crib or bassinet. So just make sure that, you're taking care of yourself, your partner's helping take care of you. And crying, it's normal for babies to cry less than 3 hours a day. But if you find that your baby is crying for more than 3 hours total a day, that would be something to let your pediatrician know about. You can take the next one, Julia.
Sure. It looks like another question came in that says, what are some practical tips for balancing recovery while also caring for a newborn? Well, I would definitely say listen to your body. If you feel like you need to rest, I think it's important to do that. Um, I also think sleep is a very important part of recovery and for both mental and physical health. And this is oftentimes a thing that many patients come having had minimal sleep. So one thing I'll often recommend is to talk with your partner about like a sleep schedule overnight For example, maybe you're going to choose that you're not going to breastfeed one of those babies overnight for one of the feedings, and your partner can give the baby a bottle so that you can guarantee yourself a 4-hour window of sleep. And then at the same time, you can try to provide for your partner that same big chunk of sleep so that they're healthy as well.
Okay, so another question, what resources or support systems do you recommend for new parents who may feel overwhelmed? So, the American Academy of Pediatrics has some great online resources. As we mentioned before, if you're breastfeeding, lactation consultants are amazing. They're super, super helpful. And I would say looking for local groups of other new moms who are going through similar situations, that can be really helpful just to talk to people who are going through the same thing you're going through. And you can, every community usually has a group of new moms that you could find and join. And Julianne, you want to take the next one?
Yes, I don't know if I have any more questions. Do you see any more, Dr. Henderson? I'm trying to find them. Is it under chat?
Actually, one of them, yeah, so it's under Q&A. So here, I can take this one. Somebody
Oh,
wrote,
thanks. Yeah.
um, if mom gets the RSV vaccine while pregnant, is it still recommended for the newborn? So, yeah, that's a great question. So, if mom gets the RSV vaccine at least 2 weeks before the baby is born, then we typically do not give the baby the Beyfortus shot that I was mentioning. If for some reason mom gets the RSV vaccine, but then the baby is born in less than 2 weeks, then that's more of a conversation with your pediatrician. But typically, if mom got the RSV vaccine, they've passed the antibodies onto the baby, so they're protected.
Yeah, great question. Okay, another question. If you get an epidural, can you birth in different positions or do you have to be on your back? This is a great question. So, like I was saying during the presentation, once you have an epidural, you will not have great control of your legs. So you really can't get out of bed and walk around. However, you don't have to be flat on your back, pushing in that classic pushing position. Oftentimes, we might have you push on one side, have you push on the other side, switch back to your back. The nurses also have this amazing birthing bar that they can attach to the bed where a patient can kind of grab onto a sheet and push in that position. And I've even had patients who have good control with their epidural be able to push on a modified hands and knees position. So your nurses are very passionate about meeting your labor goals and getting you that healthy vaginal delivery. So they'll definitely work with you on that. Another question I see would be for me, and maybe for Dr. Henderson. I'm not sure if you know much about it, Julie, but the question is, what are your thoughts on collecting and storing colostrum pre-delivery? Pros, cons, and how is it done? So this is actually something, to my knowledge, that has not, have not been trials to look at doing this, its safety, its efficacy, but I'm going to tell you it is a new thing being done. I first found out about it a few years ago when some of my physician patients were talking about this topic on physician moms groups. So I think the idea is, at the end of pregnancy, most patients would probably do this with manual um, breast, emptying the breast with, help me with the word, Dr. Henderson,
Like manual expression of the milk.
manual expression. Thank you. I would not recommend doing it with a breast pump because a breast pump can actually induce labor because it releases that much oxytocin. I think the theoretic risk also of doing the manual expression is you're going to release some oxytocin. So I've advised my patients, if you're going to choose to do this, wait until you're at least full term after 37 weeks. If you feel that this is creating cramping, probably best to back off. But otherwise, I think it's okay to do, and you can just also discuss this with your pediatrician about giving the baby this colostrum at some point. If you choose to do it, you would have to um, discuss how you would store it as well.
Yeah, and I agree. I think there's not a lot of data on it, but it doesn't sound like a bad idea. Like I mentioned before, colostrum is really rich in nutrients and it's great for the baby. So I think in theory, if you want to do it, great. But it's something that we're still learning more about. So I would have to read a little bit more about it, but it sounds like a good idea. Okay, so time for our last poll. So the question should appear on the screen. After today's discussion, how are you feeling about labor, delivery, and the first 30 days with your newborn? Are you feeling more confident and prepared, nervous but excited, wanting to learn more, or not really sure? Okay, good. So I feel like we got a good response, and I feel like this was helpful for some of you. That's great. Okay, so that is all we have for you this evening. Thank you so much for attending. If you ever want to come back to this webinar or if you want to send it to anyone, it will be posted in the coming days to access it. And again, thank you for being here with us, and we hope you learned something.